When you think about how the human body works,
Mhm.
it's really easy to picture it like a traditional, almost industrial factory.
Right, yeah, like a centralized system.
Exactly. You've got this central command center, say, the brain, or a major gland like the thyroid, and it just pumps chemical messengers into the bloodstream. I mean, it's literally flooding the entire circulatory system just to get a message to one specific distant location.
It's uh it's kind of the biological equivalent of broadcasting a highly classified message over a giant citywide loudspeaker. Just to talk to one single person standing in a crowded room.
Yeah.
Like, it gets the job done, sure, but it is incredibly inefficient and, quite frankly, not very precise.
And that loudspeaker analogy is exactly how we've understood endocrinology for decades.
Yeah.
But according to this massive stack of sources we're unpacking today, which includes FDA review documents, clinical trial data, some really brilliant medical patents by Dr. Fernand Labrie, and research from ISSWSH, the International Society for the Study of Women's Sexual Health.
That's a lot of data.
It is. And it all points to the fact that over 500 million years of evolution has engineered a biological loophole. We're looking at a system where individual cells, they just don't wait for the loudspeaker.
Right, they just do it themselves.
Exactly. They act as their own completely independent, highly targeted hormone factories. So our mission for this deep dive is to answer one incredibly specific question that is honestly changing the face of medicine.
Okay, lay it out.
How does prasterone, which is a synthetic version of the precursor hormone DHEA, how does it convert locally into active estrogens and androgens right inside our mucosal cells without, flooding the rest of the body?
And I think it's important to say that the implications of that question are massive for anyone listening, especially, when we start looking at the body post-menopause.
Right.
Because when the ovaries stop producing systemic estrogen, the body's tissues don't suddenly lose their biological requirement for sex steroids to maintain their health. Like, the demand is still there.
But the main factory is just completely shut down.
Exactly. So understanding how this localized cellular machinery steps in to fill that void, it's essentially a shortcut to understanding the entire future of targeted medicine.
Okay, let's unpack this, because before we can understand how this medication, prasterone, performs its magic trick inside a cell, we really have to look at the unique biological rulebook it's operating under.
Yeah, you have to start with the raw materials.
Right, and that story starts with a molecule called DHEA.
Dehydroepiandrosterone, yeah. It's a naturally occurring steroid precursor. So think of it as an inert raw material. On its own, DHEA doesn't actually actively stimulate tissue the way estrogen or testosterone does.
It's kind of waiting to be used.
Exactly. In women, during their reproductive years, about 80% of this DHEA is secreted by the adrenal glands. And the remaining 20% sort of trickles out from the ovaries.
And the sources highlight this really pivotal shift that happens at menopause.
Yeah.
Because when ovarian function shuts down, that 20% from the ovaries obviously disappears. But more importantly, the body is now entirely reliant on DHEA as the exclusive source of all estrogens and androgens. I mean, it is the only game in town for making these vital hormones.
And that would be fine, honestly, if the adrenal glands kept up their production. But they don't.
No, they really drop off.
Yeah, by the time a woman reaches menopause, her circulating DHEA levels have naturally dropped by a staggering 60% compared to her peak at age 30.
Wow. If you're listening and doing the math on that, it's a catastrophic supply chain failure. I mean, you've lost the ovarian production of estrogen, and simultaneously you have a 60% decrease in the precursor needed to make literally any replacement hormones.
Right, and because DHEA is the precursor to the androgen pool, that also means there is an immediate 60% decrease in the total androgen pool in the female body.
It's just a massive hit all at once. And that dual starvation, the lack of both estrogen and androgen, it triggers this severe cascade of effects, most notably in mucosal tissues.
Yeah, the clinical term used to be vaginal atrophy, but the medical community now more accurately calls it genitourinary syndrome of menopause, or GSM.
Let's talk about what that actually means on a physical level. Because, the clinical term sounds very sterile, but the reality for the patient isn't. The ISSWSH data describes this tissue starvation in really stark terms.
The tissues literally lose their architectural integrity.
Yes, they thin out, the cellular layers collapse, they lose their elasticity, and the nerve endings become exposed, which makes it incredibly painful because the cells literally do not have the molecular materials they need to rebuild themselves.
And the traditional medical response to this structural collapse has historically been, well, systemic hormone replacement.
Right, the loudspeaker.
Exactly. A patient takes a pill or applies a patch, and the active hormones travel through the entire circulatory system just to reach that damaged tissue.
Which, okay, I like to think of it like using a crop duster airplane. Giving systemic hormones for GSM is like flying a crop duster over an entire 500-acre farm, dumping thousands of gallons of water everywhere, just because you have one single thirsty tomato plant in the corner of your yard.
That is a great analogy, actually. You're exposing the entire body to active hormones to treat a localized issue.
And that exposure carries systemic risks, particularly regarding breast tissue and the uterine lining. You're forcing tissues that don't need the hormones to process them anyway.
But this is where evolution's elegant solution comes into play. If we connect this to the bigger picture, this introduces the central scientific concept of our deep dive: intracrinology.
Intracrinology. Okay, so contrast that with endocrinology, the crop duster. If endocrinology is spraying the whole farm, how does intracrinology solve the thirsty tomato plant problem?
So intracrinology is this biological process where inactive precursors like our raw material, DHEA, are transformed into active hormones exclusively inside specific peripheral tissues.
Inside the tissue itself.
Exactly. The hormones are never released by a central gland into the blood. They are minted entirely on site.
So instead of a crop duster, intracrinology is like having a discrete delivery truck pull up to a very specific cellular construction site. The truck drops off a load of raw materials, lumber, bricks, pipes, and then drives away.
Right. And the cell itself takes those raw materials, brings them behind a closed fence, and builds exactly what it needs internally.
That construction site metaphor, it perfectly explains this fascinating clinical mystery found in the data, because clinicians have long wondered why some postmenopausal women suffer from really severe GSM symptoms, while others are relatively asymptomatic, even though both groups have absolutely no ovarian function.
And the ISSWSH papers point out that the only difference is the efficiency of their local construction sites.
Oh, interesting.
Yeah, the asymptomatic women are either still secreting a slightly higher amount of DHEA from their adrenal glands, so more delivery trucks are arriving, or their specific vaginal tissues are just incredibly sensitive and efficient at using whatever little DHEA they do receive.
It literally all comes down to the local tissue machinery.
Exactly. And with that foundation, we can look at the modern medical intervention. If a patient's construction site is starved of materials, we can manually deliver them, and that is the role of prasterone.
Because prasterone is simply the synthetic formulation of that exact same inactive DHEA molecule, right?
You got it. And the sources detail the delivery mechanism. A medication called Intrarosa, which is a 6.5 milligram daily vaginal insert. By administering it locally, you are bypassing the bloodstream entirely.
You're just dropping the lumber right at the gates of the vaginal mucosa.
Yes, so let's follow that molecule. The insert dissolves, and the DHEA molecule arrives at the cell membrane of the vaginal epithelial cells and the smooth muscle cells. It crosses the membrane into the cytoplasm, and what it encounters inside is what researchers call the enzymatic machinery.
And this is where it gets highly specialized, because not every cell in the body has this machinery. The data explicitly notes that human vaginal smooth muscle cells uniquely express messenger RNA, mRNA, for very specific steroidogenic enzymes.
Right. These are the workers on our cellular assembly line.
Exactly. And let me highlight these specific workers. The primary ones involved here are 3-beta-hydroxysteroid dehydrogenase, 17-beta-hydroxysteroid dehydrogenase, 5-alpha-reductase, and aromatase.
Which is a mouthful.
It really is. So let's pause on that list, because instead of treating this like a biochemistry test, we really need to understand what these enzymes are actually doing. These enzymes are essentially molecular sculptors, right?
That is the perfect way to visualize it.
They grab the inactive DHEA molecule and start actively clipping off hydrogen atoms, rearranging carbon bonds, and just reshaping it.
Yeah. When DHEA enters the cell, these enzymes metabolize it through distinct concurrent chemical pathways. The 3-beta and 17-beta sculptures, for example, reshape the DHEA into active androgens like androstenedione and eventually testosterone and DHT.
Oh, wow. And then the aromatase.
Meanwhile, the aromatase enzyme takes some of those newly minted androgens and further sculpts them into active estrogens like estrone and estradiol.
Okay, wait, I have to push back here.
Go for it.
I'm looking at this assembly line. And if these local vaginal cells are suddenly churning out potent testosterone and estradiol right there in the cytoplasm, aren't we just creating the exact same systemic hormone flood we were trying to avoid with the crop duster?
It sounds like it, doesn't it?
Yeah. I mean, if a cell is filled with active estrogen, how does it not just leak out into the bloodstream and cause systemic side effects?
And that is the crucial hurdle that Dr. Labry's research on endocrinology really had to clear. If the cell just manufactured the active hormones and let them diffuse out, it would be functionally identical to swallowing a systemic pill.
Exactly.
But the brilliance of this evolutionary system is the second equally important half of endocrinology, local inactivation.
Local inactivation. So the cellular factory builds the hormones, uses them, and then actively dismantles them.
Humans possess a highly specialized biological recycling program. Unlike many species lower on the evolutionary ladder, our peripheral cells contain intracellular steroid and activating enzymes.
Okay.
The primary operators here are glucuronal transferases and sulfotransferases.
Okay, so going back to our analogies, if the steroidogenic enzymes are the molecular sculptors building the hormones, these inactivating enzymes are basically the cellular bouncers.
Yes, the bouncers with biological handcuffs.
Oh, I love that.
So here is the chronological sequence. The active testosterone and estradiol are minted on the assembly line. They immediately bind to the intracellular androgen and estrogen receptors located right there in the cell.
To do their signaling work.
Right, telling the cell to divide, to build collagen, to produce moisture.
And the second they detach from those receptors.
The bouncers pounce. The inactivating enzymes grab the active hormones and tag them with either a sulfate or a glucuronide molecule.
The handcuffs.
Exactly. Once tagged, the hormones are rendered completely inert. The data shows that 95% of the active hormones synthesized in the vaginal mucosa are inactivated right there at the site of synthesis.
Wow, 95%.
Yeah. They are transformed into harmless waste metabolites, things like ADTG or E1S, before they ever even exit the cell membrane.
So by the time anything actually reaches a bloodstream, it's just deactivated, harmless waste. It just floats through the blood, waiting for the kidneys and liver to clear it out.
It can't bind to breast tissue. It can't bind to the uterus. The localized containment is nearly absolute.
Here's where it gets really interesting, because I want to bring in the FDA review documents here. I was looking at the clinical data from the phase 3 trials, specifically studies ERC-213 and ERC-230.
Oh, the 12-week studies.
Yeah. These trials tracked postmenopausal women using the 6.5 milligram daily prasterone insert for 12 weeks. And honestly, I expected to see at least a minor spike in their blood work, some kind of leakage.
Right, you'd assume there would be a little bit.
But the serum estradiol, the active estrogen circulating in their blood, was measured at 3.36 picograms per milliliter.
And to put that number in context for everyone, the normal baseline postmenopausal value for serum estradiol is 4.17 picograms per milliliter.
Which means after 12 weeks of daily use, putting DHEA directly into the tissue, their circulating estrogen was actually 19% below the normal baseline.
The bouncers are that effective.
They really are. And the data shows their testosterone levels also remained entirely within normal postmenopausal ranges. There was absolutely zero systemic spike.
And that extreme tissue specificity, it solves one of the biggest clinical dilemmas in hormone therapy, endometrial safety.
Because when a clinician prescribes systemic estrogen, it stimulates the endometrium, the lining of the uterus, right?
Exactly. And without intervention, that stimulation can lead to endometrial hyperplasia and eventually cancer, which is why systemic estrogen is always paired with a progestin to protect the uterus.
But with endocrinology, the DHEA is only converted in the specific cells that contain those molecular sculptors. And even then, it's immediately dismantled by the bouncers. So the endometrium, which doesn't possess that same local machinery functioning in the same way, remains completely untouched.
The FDA documents confirm that the endometrium remains utterly atrophic during prasterone treatment. It receives no stimulation whatsoever.
Meaning these patients do not need to take a progestin alongside the therapy.
Exactly. It is an incredibly elegant, isolated solution.
It's just fascinating. And, you know, the dose-finding studies you mentioned in Dr. Labry's patents, they actually tested 3.25 milligram, 6.5 milligram, and 13 milligram doses.
Right.
They landed on 6.5 milligrams daily because it was this precise sweet spot,
Yeah.
the lowest efficacious dose to fully stock the construction site and rebuild the tissue without ever overwhelming the bouncers and pushing safety boundaries.
So now that we understand the mechanics of the factory, we really need to look at the physical architecture it builds.
Yeah, let's talk about the results.
Because why is delivering DHEA, which creates both estrogens and androgens superior to just applying, say, a traditional local estrogen cream.
Let's break down that division of labor, starting with the estrogenic effect.
Hmm.
When the local estrogens are produced, the sources say they cause stratification and cornification of the epithelium, which, again, very clinical terms.
So to visualize stratification, imagine a brick wall that has just crumbled down to a single row of bricks. That is the atrophic tissue. The local estrogens signal the cells to start dividing rapidly, stacking new layers of bricks on top of each other until the wall is thick and robust again.
And then cornification.
Cornification is the process of those top layers becoming tough and mature. It creates a protective barrier against friction and infection.
And the trial data visually proves this. I mean, looking at the cellular swabs, there is a massive increase in superficial cells, those tough, mature outer bricks, and a sharp decrease in peribasal cells, which are the immature, fragile cells exposed when the wall is crumbling.
Plus, we see a significant drop in vaginal pH.
Right, which brings the environment back to a healthy acidic state that prevents bacterial growth.
Exactly. That rebuilding of the wall is the estrogen's job. But the local androgens, the testosterone and DHT, they handle completely different structural elements. Elements that estrogen alone simply cannot repair.
Oh, interesting. Like what's...
The androgens are responsible for mucification, which is the production of healthy mucus. They drastically increase the density of collagen in the lamina propria, that's the deep connective tissue foundation beneath the brick wall, and they stimulate the smooth muscle layer.
So if estrogen is building the bricks, the androgens are laying the foundation, adding the mortar, and installing the plumbing for lubrication.
That's exactly it. And this brings us to a dramatic improvement in the function of the surrounding lubrication glands. And even more critically, this local testosterone significantly reduces vestibular pain, which is one of the primary physical drivers of dyspareunia, or painful intercourse.
Now, if you are listening to this, you might naturally be a bit skeptical at this point, because we are so conditioned by popular culture to think of estrogen purely as the female hormone and testosterone purely as the male hormone.
It's a huge misconception, yeah.
Think about this. Why on earth would evolution design a female reproductive tissue that fundamentally requires testosterone to function without pain?
What's fascinating here is it forces us to confront a biological reality that often gets completely ignored. Women naturally secrete 50% as much androgen as men do.
Wow, 50%?
Yeah. The female body is not exclusively estrogen-driven. It relies heavily on a robust total androgen pool for systemic collagen production, muscle strength, and vital nerve innervation.
So when menopause hits and that androgen pool drops by 60%, the tissues that rely on testosterone for their nerve health and structural integrity, they suffer just as acutely as the tissue starving for estrogen.
Prasterone's efficacy lies in its profound respect for this dual hormone biological requirement. It doesn't force a blunt, one-size-fits-all estrogen solution onto a complex tissue.
Right.
It just delivers the inert precursor, DHEA, and trusts the evolutionary brilliance of the cell to manufacture the precise physiological ratio of estrogen to androgen that it needs to heal itself.
Let's zoom out and put this all together, because the paradigm shift here is honestly breathtaking. Prasterone, or vaginal DHEA, is not a hormone therapy in the traditional sense at all. It is a highly targeted delivery of raw materials.
Yeah, it harnesses 500 million years of evolutionary engineering to allow individual cells to locally produce, locally use, and locally destroy their own estrogens and androgens.
It transforms the cell into a completely self-contained ecosystem. It's the manufacturing plant, the consumer, and the waste management facility, all operating simultaneously behind a closed cellular membrane.
And for you listening, the takeaway here extends far beyond a single treatment for postmenopausal GSM. This deep dive is really about how modern medicine is shifting its entire philosophy.
We're finally leaving the era of the systemic crop duster.
Exactly. We are learning how to read the body's local blueprints and gently mimic its most precise defense mechanisms, which leaves us standing at the edge of the ultimate frontier for endocrinology.
Oh, this is the part that really blew my mind.
Because if we know this mechanism allows peripheral tissues like the vaginal mucosa to operate as isolated, safe hormone factories, what does this imply for the rest of the human body?
Right.
The research papers we reviewed contain these brief, tantalizing notes about DHEA's role elsewhere. It acts as a powerful neurosteroid in the brain, interacting with nerve growth factor receptors to prevent the death of neurons' neuronal apoptosis.
In the brain.
Yeah. And in other studies, local conversion of DHEA has been shown to increase bone mineral density at the hip by stimulating local bone formation. And again, entirely without raising systemic hormone levels.
Wait. You're saying the brain and the bones have their own independent construction sites and bouncers, too?
They possess their own localized enzymatic machinery, yeah. So the provocative question we have to ask ourselves is this. Could this targeted cellular hormone factory approach eventually make systemic pills obsolete?
That is wild.
We could be looking at a future where we treat Alzheimer's disease in the brain or severe osteoporosis in the bones, not by flooding the entire circulatory system with heavy pharmaceuticals.
But simply by delivering the right inactive precursor to the right local enzymes, giving the cells the exact raw materials they need to rebuild their own tissues from the inside out without the collateral damage.
Exactly.
That is a staggering thought to end on. The human body is so much smarter than the tools we've historically used to treat it. Thank you for joining us on this deep dive into the fascinating world of endocrinology.
It's been great.
Until next time, keep exploring the science, and remember to trust the quiet, incredibly precise work happening inside your own cells.